is accurately described as an international expert in this field. So we welcome him from America. He's a great eminence, long experience, and has much to tell us with some very new data, which is very exciting. And he wouldn't tell us last night. He was saving it for today. So we're all waiting to see it. So it's a great joy to welcome him from the States and to ask him now to make his presentation. Dr. Lerner.
Thank you very much. Before I start, I would like to let you know that I never have been subject to such wonderful hospitality all the way. It's been marvelous, and I certainly appreciate it. It's been nice to get to know some of you from your organization. Everyone whom I've met has been interesting, and I wish I could know you more. I also have been extraordinarily pleased to be with the other scientists here who I recognize them as heroes, and are heroines, and I recognize all of you as heroines as well. Just a bit extemporaneously, Leonard was talking about the difficulties of a new paradigm, a new understanding of a new disease, and all of us, perhaps myself included, recognize the difficulties when one is saying something new. I hope that our visit can help make your task a little easier. My own work has been made very much easier, and the new data that I shall present is the work of patients whom I have seen. Approximately a year and a half ago, Ken Gill and Carolyn Gill. Carolyn's been a patient for about 7 years who is remarkably better. And Ken, a retired GM executive in retirement, started the Martin Lerner Foundation, and the data which I shall show at the end of this is the result of patient work, well over a year of spending time seeing and collecting data from my office, and we shall review ultimately after this background 6 years of data, 180 some odd patients followed for 6 years with 5,000 visits and over 45,000 pieces of data to come to the conclusions. But how did we get there? Incidentally, the reason they started all of this was because they recognized that I was the poorest salesman that they had ever seen. A number of the diagnostic and therapeutic methods reported here are the subject of issued patents. I have patents because what we saw was new, and I didn't like to belong to country clubs. And several patent applications are pending, and if anyone is interested, they're available. The work that I'm presenting actually is mine, plus a number of really expert collaborators. My own background in infectious diseases and clinical virology and internal medicine. We've had cardiological help. We've had nuclear medicine help. We've had pathologic anatomy help. We've had superb statistical help from Tom Fitzgerald. We've had virologic help from Washington University. We will show you a placebo-controlled trial, small one, supported by GlaxoSmithKline Wellcome, and molecular biological help from Sayo Bekovic. The mission of the foundation is to advance the research and treatment and dissemination an understanding of the chronic fatigue syndrome and the experience of the people who are collecting these data I've already spoken about. And the Foundation hopes to establish a molecular biology laboratory to develop the specific diagnostic testing for subsets of the chronic fatigue syndrome and a training center dedicated to the training of medical professionals in the treatment of patients with the chronic fatigue syndrome. I'm a very practical person, and this is hanging in every one of my 7 examining rooms. And the energy index point score, the capacity for living, is determined by the patient at each visit with my help. And there are 10 grades. You can do what I did before I became ill. Grade 0 can't get out of bed. Grade 1, perhaps out of bed daily for an hour. Grade 2, etc. Grade 4, that's a particular grade we'll notice as we get along, for out of bed 4 to 6 hours a day, doing sitting up or standing, doing very little. Grade 5, one can work at a sedentary job or do most of the things to manage a household. Below that, one belongs to the Facuto criteria. Above it, one's recovering. At 6, one still has to lie down, perhaps sneaking a rest at noon at work, but able to keep a sedentary job and perhaps a little social activities. Grade 7 don't have to lie down at all. Grade 8 can begin to exercise, and indeed, I ask that our patients not exercise until they reach grade 7 and approaching grade 8, because this brings on the post-exertional fatigue, which I hope which is part of the chronic fatigue syndrome, which clearly is, you will hear more about as we go along. 8, 9, and 10, they're closer to normal. Now, the symptoms of the chronic fatigue syndrome are parallel completely with the energy index point score. And these symptoms decrease remarkably as one becomes 6, 7, and 8 in the energy index point score. And at every patient visit, and in the patient visits that we have seen, and in order to maintain the safety of what we are doing, I see my patients every 6 weeks, and the energy index point score is determined at each of our visits. This is my foundation who's doing all these fancy things. Whenever we have a metric, which is what the energy index point score is, we have to find out, does it work? Is it meaningful? And we validated our energy index point score, a simple metric, by 2 simple means. Firstly, 20 CFS patients, predominantly women, were compared with 22 healthy adults, predominantly women, same age. Energy index point score of the CFS patients, 3.6. Their mean energy index point score of the healthy people, 9.9. The probability of the difference is very clear and meaningful. Now, the effect size, Dr. Fitzgerald, professional statistician, tells us from this a small change of 0.25, a medium change of 0.5, a 0.8 of a unit change, a large change, and we'll remember that. The second means of validation was one which would fit many of criteria. We took the fatigue severity score, a score for measuring fatigue by a questionnaire, and the energy index point score, and 55 consecutive patients in 2006 were analyzed by both means, and then they were compared, and our professional statistician said that they correlated really quite well, so that the simple energy index point score, what is the patient able to do, appears to be a simple valid metric by knowing how much disability our chronic fatigue patient has. Now, from the very beginning, clinically, as I see patients, the chronic fatigue syndrome seemed to be a prolonged infectious mononucleosis, and infectious mononucleosis the syndrome can be caused by the very famous by now herpesviruses, Epstein-Barr virus, cytomegalovirus, and human herpesvirus 6, in continuing, and you'll hear more about this, abortive multiplication with systemic and cardiac involvement. You might be interested that following the publication of our most recent placebo-controlled trial, the American College of Physicians came to me and asked me to be the expert for them on their website of evaluating all papers written about the chronic fatigue syndrome. And then, obviously, specific antiviral pharmacokinetically delivered therapy we hypothesized would help patients with the Epstein-Barr virus. Incidentally, the initial appearance of Epstein-Barr virus in the first-time primary infection is a cacophony, an explosion of immunologic everything that we can do to respond to this virus, which we never can get rid of, but we can put it to sleep as both ends of the double-stranded DNA close upon each other, forming an episome in the nucleus, doing nothing. And that's all the healthy person can do that those of us who have chronic fatigue syndrome can't do. Now, this is what these viruses look like. I've been told by my wife in instructions for this August meeting not to shake the pointer, so I'll try very hard not to do it. These are the double-stranded DNA. These are the largest of all human viruses. They have 300 genes, and as John indicated, they have early genes, middle genes, and late genes, ultimately leading to a lytic virus, which comes out of the nucleus, picks up a lipid coat, ultimately comes out of the cytoplasm and picks up a second lipid coat and has protein epitopes, antigens, which we see and measure as antibody to these viruses. Those genetic parts that put the whole thing together are present in the tegument. And these tegument genes, ultimate tegument proteins, at the middle level of multiplication, our work suggests are critical to the chronic fatigue syndrome. Here, another caricature of how we visualize this illness. After infected, we like to close this up, be finished with these viruses. At any time, the virus wants to open up. And in the chronic fatigue syndrome, we visualize that parts, genes, are made, but that the virus is never put together and the whole virus is not formed. Now, evidence in support of this continued immunologic cacophony been found by many workers, less sophisticated than the elegant work we've heard from Dr. Kerr. Elevated lymphocyte levels of 2,5-A, RNase L, brain abnormalities, increased immune reactivity of every type, T cells, natural killer cells, etc., completely consistent with virus infections. Physiologic test of why we're dizzy, first called a reflex. We believe it's secondary to the very common cardiac involvement of patients with chronic fatigue syndrome. And then we hope that this is not completely true today. No specific tests to implicate any single virus. We began being extraordinarily practical in 1997, and we found 18 patients with elevated IgG antibodies. I'd like to stop here a second to say that to the infectious disease clinician interested in virus infection, an IgG antibody means that the whole virus is formed and nothing is happening now. That things are happening now when a larger, less specific antibody, the IgM antibody, is made, and typically in patients with a chronic fatigue syndrome, with one of the herpesviruses, the cytomegalovirus, if you will, we don't see any IgM antibody. At any rate, these 18 CFS patients were treated with pharmacokinetic doses, that is the levels in the serum for 85% of the minutes of the day were above the IC50, the infectious dose 50, necessary to prevent the virus from multiplying. And 24 weeks later, 13 of the 18 patients had returned to their healthy state, and this was published in 1997. And except for the fact that our work was with intravenous ganciclovir, the work at Stanford with Valcide is exactly what we had shown some years earlier. We then went to another herpesvirus, Epstein-Barr virus, one of the three viruses that we implicated. And these patients, we were interested only in patients not who had past experience with Epstein-Barr virus, but those which had some serologic evidence of active ongoing infection. And we chose two such antibodies. One, a recombinant P18 antigen to the viral capsid, which is at about the 90th step of the 200th genes that make this virus, but particularly further along than the EA antibody, which is only the first 30-some-odd genes of the sequence of early, middle, and late genes. And interestingly, there were two groups of patients among these 19 patients treated with valacyclovir, which, when given in the dosages that we gave, had levels higher than necessary to inhibit the multiplication. We found that 10 of these people, but 9 of them didn't get better. 10 traveled from an energy index point score average to an energy index point score close to 7, a remarkable change. And 9 of them did not. And remarkably, to our surprise, the 9 who did not get well also had experienced IgG antibody to cytomegalovirus. What in the world did this mean? We suggested that it might mean that they had the two of them at the same time. That was really a brilliant suggestion. Very obvious. The third preliminary test of an antiviral drug was just published bit ago. This was a randomized, placebo-controlled, small trial testing Epstein-Barr virus in Facundo International Definition of the Chronic Fatigue Syndrome, supported by Glaxo Wellcome. And the placebo-controlled trial went on for 6 months, and at this 6-month period, there was a 1.4 energy index point unit score in favor of those given the drug. We looked at these same patients using the Stanford heart disease criteria for determining energy utilization, and they studied heart disease patients. Now, this clearly differentiates the patients receiving drug. These are the placebos. These are the patients receiving drug. Then at 6 months, everyone was given valacyclovir, and notice how everyone improved. The total difference was 1.4 units, which was very promising. Now, if one looks at the demographics of patients with the chronic fatigue syndrome, they're very much the same, as you know very well, and has been outlined by Leonard and John. These are healthy people in their late 30s to 40s. They don't have previous diseases. Frequently, they're athletes. They don't have any other conditions that we can recognize. And the populations and the demographics stay the same through the years. The serum antibody tests that we use to recognize these patients, we might say another word about the viral capsid antigen, which is a late gene of the Epstein-Barr virus genome. This is recognized in every textbook of virology to mean that there's active multiplication of the virus. Now, the original studies of the antibody sequence of the Epstein-Barr virus studied the IgM antibody and said that at 3 months, the IgM antibody is not present. But if one uses this very purified recombinant antigen, we found a significant segment of patients with the Epstein-Barr virus that have this unequivocal evidence of ongoing Epstein-Barr virus multiplication. The second group of Epstein-Barr virus active patients did not have IgM P18 VCA antibody, but they had diffuse antibody to EA. And by now you know that the EA antibody represents multiplication, but only at the level of the first 30 genes. And we know, and others have shown, that if you look at patients with with chronic fatigue syndrome and compare them to normals, there is no difference between the healthy individual and the chronic fatigue syndrome patients in EA antibody. So what do you do with that? We're not measuring middle and late gene activity. Therefore, our suggestion that in order to produce the chronic fatigue syndrome, one has to get beyond these early gene products. Now, things were a little bit easier with cytomegalovirus. Of course, we found IgG antibody in the CFS patients that we suspected to have this, but there was no IgM antibody. We were extraordinarily fortunate to have available to us two gene products of middle gene activity at about the place of the DNA polymerase of the virus, P52 and CM2, and we ran about 1,000 assays in our laboratory, and we found positivity in 50-some-odd patients when we found only 10 who had IgM antibody to the whole virus in the classical means. Now, HHV6 we have considered meaningful. If there was a positive antibody titer, all done, the HHV6 titers we do not do in our own laboratory, and this is considered positive. At the present time, we have no early antigen assay to use, and what we use is the presence of positive IgG antibody plus the Facundo International criteria, plus, as you will see, abnormal 24-hour ECG monitors. This is an extraordinarily interesting slide. This is a very early patient, cytomegalovirus chronic fatigue syndrome. And notice here's the 0. This is the IgG titer. It's there, indicating nothing is happening. This patient is well. There's no IgM antibody. These are the P52 and CM2 titers. Incidentally, the IgM antibody to P52 and CM2 are extraordinarily useful in making the diagnosis of congenital cytomegalovirus infection in the first 3 months of pregnancy. And this is an extraordinarily sensitive assay, this is the only clinical use that it's had. But when we studied this, we found that this was positive frequently in patients with the chronic fatigue syndrome. And here we are, high titers, treated with ganciclovir, and down they go. So you don't have to be too bright to say that middle-level genes are important and maybe causative. Very early, we were interested in the cardiac manifestations because in my prior interest, I had been extraordinarily interested for a long time in Coxsackie virus myocarditis. And I was very impressed with the pain, the chest pain that chronic fatigue syndrome patients have. It doesn't come on with exercise. It comes on at the end of the day. So very, very tired. And their patients are dizzy. And when we looked at the 24-hour ECG monitors of these patients, as you will see in a moment, there is rapid heartbeat tachycardia at rest. And when is there tachycardia? There's tachycardia when neurologic mechanisms tell the heart to work harder. But the heart working in the CFS patient is working hard all the time to do the best it can. And then it doesn't do quite so well, so it begins to dilate and produces a balloon heart, which gets bigger and less efficient as time goes on. And then we did something that renal people do all the time. You want to know something, so you biopsy the heart. We had the best cardiologist in our group do biopsies, and we did 7 biopsies. Of these 7 biopsies, 2 patients had very serious post-operative cardiac bleeds. Fortunately, none of them died, and it is our belief that the heart in the CFS patient is friable, and we do not do cardiac biopsies anymore, and I've written that we shouldn't in patients with the chronic fatigue syndrome. Incidentally, we looked for whole virus by PCR test in these biopsies, and we still have pieces of them. This was done in several laboratories, and PCR to whole virus was negative. We are waiting to be able to do the appropriate tests looking for middle-level antigens. Here we are. When one has a myocardial infarction, the This is the QRS wave. This is the contraction of the heart. And this is the electrical repolarization recovery. The T wave, the recovery wave, should be positive. And here it is in this young woman, completely negative, further deeper negative. The patient was treated, and the inversions were less acute. Clearly, we had to look at what this meant. These T-wave inversions occur with many things. They occur with heart attacks, myocardial infarctions, with abnormal electrolytes, sodium, potassium, calcium, magnesium. But we looked at non-CFS patients and CFS patients for T-wave inversions and T-wave flattenings, and there was a difference. They occurred in 96% of patients with a chronic fatigue syndrome, and our statistician tells us that the absence of this simple test, these T-wave inversions, makes the presence of the chronic fatigue syndrome unlikely. And we utilized friends of ours at the hospital. This is the work of Howard Dworkin, who is professor of nuclear medicine at the hospital. And we looked at the contraction of the hearts of patients with a chronic fatigue syndrome. And they, instead of being synchronous, symmetrical, they dilated when they weren't supposed to. They got big. They had tardokinesis. And when I pulled about 10 of these patients together for my friend Howard and I to look at together, he was astounded. And to our knowledge, this was the first recognition of the heart disease. This is one of the biopsies that we never should have done. Now, I know you're not pathologists, but the muscle in the heart is a syncytium, and it is parallel, and it has some of the architectural beauty of the buildings here in London, which I have enjoyed tremendously. There is total disarray of the myofibers, and then we lose them. They burst by apoptosis, and they're replaced by this blue scar. And what in the world is a fat molecule doing in the heart? And we don't do this anymore. I've got some specimens left, but I don't recommend that we do this. These are the initial demographics of 187 patients followed for 6 years in my office. And we were surprised that when we looked at them, there were clearly two groups. Two groups. One group that had the herpesviruses, Epstein-Barr virus, cytomegalovirus, or Herpesvirus 6, and a second group having these same herpes viruses plus a co-infection. And the co-infection which was most common was chronic Lyme disease, adult rheumatic fever, and a second tick-borne infection, babesiosis. In my efforts to meet the time criteria, I didn't say something that certainly ought to be said here, and that is that these herpes viruses hide in a given cell of latency. The Epstein-Barr virus hides in the B lymphocytes. The cytomegalovirus hides in the bone marrow in latency, in the macrophage, our precursor to the macrophage. In the bone marrow, the Herpesvirus 6 hides in the T lymphocytes. These patients had the same sex ratio again. Incidentally, note that there were 124 Group A and 63 Group B. This is brand new work. We've not submitted any of this for publication yet. The sex ratio was right. These were previously completely healthy. And at the time that the guilds did this assessment, they had been treated by me for some 3 odd years. And when one looked at how many of each of the viruses, from now on the data only relate to group A. We have not gotten to look at the data for group B, and as a matter of fact, we've not finished the analyses for group A. Single viruses were interesting. 25% of the 124, 31 patients, were Epstein-Barr virus. 18 of them were cytomegalovirus. That is, there was no Epstein-Barr virus in these patients, no HHV6. And interesting, there were 1.6% which were HHV6 alone. But if one looks at multiple herpes virus infections in these 124 patients, we found that 60% of them are these multiple infections, and every possible combination of the viruses are seen. And since, at least for the medicines that I use, valacyclovir is extraordinarily effective against Epstein-Barr virus and has essentially no activity against cytomegalovirus or herpesvirus 6. However, valacyclovir is safe if the patient drinks enough water. The only side effect is renal concretions if they don't drink enough. I favor, if I can use valacyclovir, and moreover, it is my bias without evidence that valacyclovir is more effective against Epstein-Barr virus than valganciclovir, Valcyte, which in vitro is active against the 3 viruses, but which at the present time is the only agent that we have active against cytomegalovirus and herpesvirus type 6. So the conclusion here is that the chronic fatigue syndrome is herpesvirus persistent abortive infection by one or several of the 3 viruses. Now, it's interesting, as one looked at the data with the expertise of the foundation. Over the 6 years, there is an energy index point score for each of the 24 points of the every 3-month energy index point score. And there are a mean of 52 patients per point for each of the points of the 24 points plus the one of the baseline here. And the energy index point scores are the means as well. Notice that. And I took everybody. We have people who were sick 6 months, a few, but we took them who were sick over 10 years, 18 years. I did not exclude anyone. And the energy index point score rose here almost 2 units at the mean. And this was looked at carefully by Tom Fitzgerald, our statistician, and the chances of these data occurring by chance are 2 out of 1,000, so that the data mean that 998 times out of 1,000 these data are meaningful. Now, if one looks at how much better did these patients become, a patient who is sick, not 5, but 6, you remember, can keep a job. It's not too physical, but must lie down for 15 or 20 minutes, has some leftover for some social activities at home. 7, one doesn't need to lie down at all. And 8, at 8, our patient can begin to exercise. We find that starting to exercise at a lower energy index point score makes the patient worse. So I'm in favor of exercise, but only when you're ready And if you will notice, the remarkable rises in energy index point score occur after 6 months of therapy. And how does a simple clinician get through those initial periods? Well, I simply tell my patient, have you ever had an appendectomy? When do you begin to feel okay? It takes that long for healing to occur. At any rate, if we look a little further at these data, how many of our patients are 9 or 10? That is, they can do what they want to. They can play tennis like one day I did, about 10%. How many of them, 4 plus 3, are up to 7 or 8? 27%. How many of them are up to 6? About a third of them. We helped 90 patients, 72% of all of the patients we saw, and 27.5% of our patients did not respond. We have not yet analyzed these patients, as we shall, to see if there may be any differences between them. Incidentally, there was an exclusion which I used. I excluded any patient who came to see me who did not stay in treatment for 6 months. If he stayed in treatment for 6 months, we counted him, and the reason for this is we didn't see any real improvement until the patient was 6 months along. I see I'm really doing quite well in terms of time. What do we make out of this? I really recommend that the energy index point score be used. It's tremendously simple. We hang these signs in every one of our rooms. Patient decides where he is. Interesting, just between you and I, the early energy index point scores were done by me, and I scored my patient lower than they scored themselves. So these are minimalistic data. I was taught that you'd better look at your data harder than any other person ever looks at it, because none of us wants to spend the amount of efforts that we spend unless we're finding something. And as a matter of fact, the story that I've told over these 40 minutes or so is a story which told itself. One study led to the next, to the simple questions, et cetera, et cetera. The energy index point score is a validated, simple metric, and it works. It's what the patient can. I ask what my patient can do. The patient with a chronic fatigue syndrome can't do, and symptoms follow, and complaints vary with the psychological state of the individual, all of us. This inclusive study indicates that significant benefit occurred in patients treated with pharmacokinetically delivered antiviral therapy within the net of safety which we used. The initial mean EI was 4.2. Lots of data to make this, 52 patients per point of the 25. And the increase in 1.8 units is a large increase effect size. And as done, and I certainly wore a belt and suspenders with each of these patients. I'm certainly aware of the data with AIDS patients, of the toxicity of Valgan, cyclovir, Valsite, to the bone marrow, to the liver, et cetera. There was no toxicity to any patient in this series with long-term therapy, which is necessary. And this benefit is statistically significant. And recognition of the 3-virus herpesvirus causation of at least a large number of CFS patients in Group B, and the variable 3 herpesvirus cause, and the presence of Group B is extraordinarily important in considering therapy for the chronic fatigue syndrome. And indeed, this inclusive study confirms our original hypothesis that the chronic fatigue syndrome may be a failure of some of us to put these herpesviruses, any of the three or several of the three, into latency. We had better recognize these co-infections, which are mimickers of the chronic fatigue syndrome. And the patients with the co-infection certainly need to be treated as well, and we'll have more to say about that at another time. There is significant cardiac muscle disease in CFS illness, and I hope you all are convinced of this, and that long-term, appropriately delivered antiviral therapy leads to a marked improvement in the functional capacity of our patients to live a more normal life. I think that's it.
You mentioned Herpesvirus. Can you see any relation with CFS?
I am impressed by the work of Dr. Shia, and I would like to hear more. My work with Coxsackie viruses is of a previous era, and I have not really looked at the presence of Coxsackie virus in the meaningful causation of the chronic fatigue syndrome.
With your treatment, is there any improvement in the heart?
Thank you for asking that. There is remarkable improvement in the heart. The ejection fractions increase, dilatation of the heart disappears, yes. There is a remarkable improvement. Of course, the longer our patient has been ill, the more the complicating diseases. My prejudice is the less likely this is to occur. But yes, there is a remarkable improvement in many of our patients in cardiac function, in terms of the Holter monitor, in terms of the efficiency of cardiac contraction as well.
I'm sorry, what is the average time for the heart to improve with your antiviral therapy?
I think really one of the important issues in the upcoming trials is that the trial be long enough. I think the minimum period of a study would be 9 months. Actually, what I do is I treat my patients for 1 year. If there's no improvement in a year, I tell them it's unlikely that there will be improvement. But we begin to see things remarkably at about 5 months, and then the asymptote is from about 5 to 7. And the interesting thing is that they stay. Now, what happens, what I like to do is to get my patients off drugs. And about 10 or 15, and first we taper the dosage, and then we stop, and we look a month or 2 months later, and we measure their energy index point score and their return of symptoms. And if there is a lower dosage which will maintain their height of the energy index point score, we will maintain a lower dosage. If we can stop it, we stop it. If we can't, we maintain therapy with careful monitoring of safety. And there is approximately 15% whom we can take off therapy entirely. There's perhaps 20% whom we can maintain on a lower dosage, and the remainder of the patients stay on full therapy.
How can someone in this country with ME get this antiviral treatment? Because it's, it's a bit like a carrot really in front of the donkey with all this hope. And also, is it ever too late for someone with chronic ME to have this treatment? Thank you.
Thank
you.
There are many nuances to the data that we have shown, and there are many, many things that I've learned the hard way. What I'm hoping to do is to make a series of teaching videotapes for our physicians and make these available.
The question, you're asking the wrong man. He prescribes in the States, but the drug is available in the UK. It's widely used in other spheres to protect against viral infection. So the drug is available. The question is, does the NHS allow it to be available? And that's the big issue. And that's the question we want to raise with the Ministry of Health and people like that. But the question really is, can physicians prescribe this if they feel it's appropriate? And a number of people are asking for this from physicians who are willing to prescribe. And we're trying to work out the ground rules for this to apply in the UK. But the drug is available. It's not something that's magic and miles away. All these acyclovir, ganciclovir, and the Valgan derivatives, the Val derivatives, are all available. But it's a matter of policy, and it's a matter of making it available for normal prescription by physicians who are dealing with patients in the way that a GP would be dealing with many of you. So we'll look into that. Thank you very, very much, Martin. That was terrific stuff.